Today, we are joined by three amazing speakers to help us dig into health insurance benefit design from the perspective of patients living with insulin-requiring diabetes. Specifically, what drugs, devices, and supplies are covered and what cost sharing applies, and the policy levers to expand what's covered and improve affordability. For those of you who are new to the Center on Health Insurance Reforms, we are a nationally recognized team of health insurance experts within Georgetown University's McCourt School of Public Policy. We conduct legal and policy research and analysis, publish reports, and provide technical assistance to stakeholders and policymakers across the country, both at the federal and state levels. We have teamed up with the Leona M. and Harry B. Helmsley Charitable Trust to apply our passion for private health insurance to better understand the issues facing patients with diabetes who require insulin and the reforms that can improve coverage for them. As part of that effort, we're thrilled to share with you today some of what we have learned so far and bring to you some of the incredible people we have encountered who are leading efforts on the ground with real-world personal advocacy and policy-making experiences. Before we get started, I need to cover a few housekeeping matters. First, we will be recording this and we'll share a link after the call. If you like what you hear today, please share the recording with others in your network to get the word out. Second, the chat is open if you have any technical issues to flag for us. Otherwise, we'll be posting links to a few key resources there during our discussion. But third, we'll have time at the end to take your questions. So please submit your questions by clicking the Q&A button and typing them in there. Feel free to add questions as we go. Our team will be monitoring the questions throughout the webinar. And finally, I'd like to announce our speakers. Kicking us off will be Cheer Assistant Research Professor Amy Killalay. Amy joined our team at Cheer to work on this project, and I couldn't be happier to have them. Amy has over 15 years of experience in public health law and policy with a focus on medication access and affordability. Today, Amy will be sharing some more background from the research our team has been doing and preliminary findings from a forthcoming issue brief. Following Amy, I'm excited to say that we'll hear from Hugh O'Hara, a volunteer with Breakthrough T1D in Illinois and a parent to a teenager with type 1 diabetes. Hugh's oldest daughter, Rory, was diagnosed with T1D in 2016, and Hugh, Rory, and the rest of their family have been deeply involved in T1D-related advocacy and fundraising ever since. Last but not least, I'm thrilled to introduce Kyla Hoskins, Deputy Commissioner of Affordability Programs at the Colorado Department of Regulatory Agencies. Before being promoted to her current role, Kyla directed implementation of the Colorado Option Program, which, as she'll explain, has taken an innovative approach to diabetes coverage, among other things. Now, without further ado, I'll turn it over to Amy to get us started.
Terrific. Thanks you so much, Christine. And hello, everyone. I'm just going to take a moment and share my screen. Okay. And with that, it's great to be with you this afternoon and to set up some great speakers. What I'm going to do is give the context for the more specific perspectives that Hugh and Kyla are going to share. And I'm going to provide an overview of some of the challenges and pain points for diabetes affordability and access that we uncovered during the research Christine alluded to, and give you a sense of some of the trends we saw in the research of what states are doing to address those pain points. This webinar is part of, as Christine said, a broader project that Georgetown Cheer is leading on diabetes access and affordability. And so we have a written product that we're very excited about that is going to go into a lot more detail on some of the issues I'm about to go over. So consider this a preview of that work. And just to kind of set up that scope, we're looked in the issue brief at state private insurance policy considerations really designed to increase access to and affordability for the range of services that people with insulin-requiring diabetes need to stay healthy. And the brief summarizes the extensive environmental scan, literature review research that we did, as well as informant interviews. And we focused on 6 study states, the ones that you see there in front of you. And we're really pleased to hear that, or that you will hear from folks from 2 of the study states, Colorado and Illinois, later today. Our focus on the issue brief was on a swath of the private insurance market, the swath that is regulated by the state. So it's a smaller swath of the broader insurance market, but a really important one nonetheless. And those plans that we're going to be referring to throughout include the three sort of buckets, the categories that you see in front of you. You've got individual and family plans that are sold on the marketplace, the ACA marketplaces, off the ACA marketplaces. You've got fully insured, small, and then large group employer coverage. And you'll see a little glimpse of this on the webinar today, but even across those state regulated products, we still see variation in first, both the array of federal laws that apply to each category, and that really makes creating a uniform and consistent regulatory structure difficult. And it also means that some of the opportunities at the state level might be different depending on what category of private insurance we're talking about. So we'll start to get into some of those details as well. And our issue brief, even the topic of affordability and access for diabetes is quite broad. So we had a lot of internal discussion and feedback from external experts, and we landed on these three focus areas for the first issue brief. You've got coverage requirements that include mandates for the suite of services that people with insulin-requiring diabetes need, cost-sharing protections that really gets at the affordability of those services, and then utilization management. And there, a prime focus is prior authorization. For today, we're going to cover those first two buckets, coverage requirements and cost-sharing protections. But stay tuned, because we will be going into lots of detail on prior authorization on our December webinar. So coverage and affordability, before we get into the policy levers to get at this, we want to provide you with a little bit of an overview as to the pain points, the challenges that were identified in the environmental scan and the informant interviews, because in many ways, these set up what policymakers are responding to and what they should be responding to. And the themes really were many, and these were some that came up again and again and again. One is affordability. That was really the challenge and the pain point that came up the most, that was talked about with the most level of challenge by particularly by patient advocates and people living with insulin-requiring diabetes that we talked to. And even sort of diving deeper into that affordability challenge, not just insulin. Certainly insulin is a key affordability challenge for people, but access to devices like CGMs and insulin pumps, increasingly difficult for folks to afford, especially with high deductibles and co-insurance for those services. We also found that plans vary quite a bit in terms of how they cover things, what they cover, what the cost sharing for the consumer is. And that makes enrollment decisions very difficult for people with diabetes. And this came up, and one of the reasons we're so happy to have Hugh on today, it came up particularly when we were talking to parents of younger folks and folks who had gone through this transition from being a young person with diabetes to becoming an adult. And you sort of have this like twofold transition of pediatric care to an adult care model that's happening at the same time that lots of other transition changes are happening, including moving off of a parent's insurance and having to kind of be thrown into a very high stakes set of decisions about coverage. And that variability combined with the high stakes of the choices, what was identified as a big challenge. So, and that really just kind of, I think, touches the surface in terms of the challenges that we uncovered. But those were some of the ones that came up most often, and led us to uncover sort of four main findings that I'm gonna summarize briefly for you. And I think set up again, the next speakers are going to go into a little bit more detail than I'll go in here. And so our first finding is really that insulin copay caps are really important, but even that policy lever does vary, and how that's set up really does impact how impactful the policy mechanism is. So, this is one that's gained a lot of traction, particularly over the past several years, where lots of states, including our 6 study states, all 6 of them, have enacted via state legislation a cap on the cost sharing that somebody in a state regulated private insurance plan will pay for their monthly insulin prescription. So first, and this one is somewhat intuitive, the lower the cap, the lower that amount is set at, the more protection for the consumer. And that makes sense. But if you think about, some of the early states are just sort of trying to figure out the sweet spot of where to set the cap, they may have started a little high. So, a $100 cap is not going to be quite as protective as a much lower cap. And we now see studies that sort of bear this out. And in addition to the amount of the cap, what the cap covers also matters. So you can set a cap that caps all monthly insulin prescriptions, or you could set a cap that says each individual prescription has an X dollar amount cap. And collective caps that cover all the insulin somebody might be prescribed are going to be more protective for someone, and many people are, who is on multiple insulin prescriptions. So these sort of nuance in a cap that is, really prolific these days really matter in terms of the protection that it covers. And you can see here, all 6 of our study states included a cap on insulin, but varied in terms of the dollar amount and whether that cap was collective or individual. And in addition to that, in addition to these insulin copay caps, we also see a cap on other devices, including CGMs. That's a little bit less common, but one that that is happening more frequently. And sort of a nice segue to that point, a big finding that we saw, and this relates to the pain point, it's not just insulin, the affordability, particularly for devices. And when we think about the technology boom that we see in diabetes, these devices that are coming on the market are not cheap. And so if you are in a plan with a high deductible that has coinsurance attached to medical devices, that's going to be a burden for the consumer to afford. And so, we found that some states are considering and have put in place caps, not just on the insulin cost sharing, but on CGM cost sharing as well. And again, and this is going to become an important distinction from what I'm about to talk about, these types of caps on the CGMs and insulin, they apply to the entire state-regulated private insurance market. So these are our legislative mechanisms that are applying to the entirety of the state-regulated private insurance market. So to sort of contrast that, the legislative copays are applying to the entirety of the market, and then there are more nuanced, more specific mechanisms that can actually go even farther than the copay caps that we just talked about, and those are through standardized plan options. And I'm going to let Kyla give you the specifics of what Colorado has done in this area. But it's really an interesting opportunity to be very specific in the types of cost sharing protections that are provided, so specific as you can sort of tailor it to diabetes services. So this is a mechanism that applies to a smaller swath of the market, typically a subset of plans that are in the individual and the small group markets. But it's a mechanism to offer low or zero cost sharing for a suite of diabetes services. And the states that are rolling this out, it's exciting to watch and kind of see how that's impacting access in those states. And it's a relatively nascent development, and we'll hear more about that, how that's going in Colorado. Finally, our penultimate third finding is that the vast majority of the states sort of writ large, and all 6 of our study states, had legislative coverage mandates. And this is thanks to many of you are on the line are diabetes advocates who have been working on this for years. So, concerted advocacy effort at the state level really brought to fruition these state level coverage mandates that were passed now, though, 2 decades ago in the late 90s, early 2000s, in most cases. So in those 2 decades, the standard of care for diabetes has changed quite a bit. And so, you see that those coverage mandates are still incredibly important, but in some ways are outdated and don't include the specificity of all the different types of devices and services available now for diabetes. So, there are a couple of different options related to those coverage mandates, and coverage sort of in general. One is to just go back legislatively and open up those coverage mandates to update them. And the second is to, again, you kind of look at a smaller swath of the market. You're not going to get at the entirety of the state-regulated private insurance market, but you could kind of look at a mechanism that covers any plan subject to essential health benefits through the ACA. So that will be the individual and small group markets. And update that standard, the essential health benefit standard, to include more diabetes specific coverage options. And, as again, like preview for the report, more nuanced discussion about why and how do you do each, but there's pros and cons. As many of you out there, particularly in states with conservative governors or legislatures, know, getting legislation passed, especially coverage mandates, is difficult in some states, impossible in other states. So that may not be a viable option, even if it is the option that provides the coverage for the entire private, state-regulated private insurance market. The EHB option often does not require state legislation to update, but the trade-off there is that it's not going to include the same swath of private insurance plans as a coverage mandate. So there's pros and cons. There's sort of decision making at every level. And then the last consideration is about health equity and process. And this was, I think, an important way for process to influence ultimately what policies were a state chose to go with and how they chose to implement those policies. So we have found in the literature and informal interviews, diabetes access challenges disproportionately impact certain communities. And so to really sort of get at that and address disparities, policies need to be tailored to those communities. And what we found is that states are really starting to embrace an equity lens when they think about policy levers to address conditions like diabetes that disproportionately impact certain communities. And just as a process point, that has looked like states engaging different stakeholders with lived experience, with other expertise, to really make sure that the day-to-day reality of people trying to access services inform the policies that address those challenges. So that is the overview, and hopefully provide some context for the more specifics we'll get into with our speakers. But just to quickly plug, next steps, keep an eye out. The issue brief is making its way through finalization. So we are expecting release in December of this year. Be the first to get it. You can scan the QR code, or we'll put a link into the chat. You can sign up for updates. And then, as we said, prior authorization, if you're interested in prior authorization, and you should be, the next webinar in the series is going to be December 6th, and we'll be diving deep on that topic. So with that, I will pass it back over to Christine.
Thanks so much, Amy. That was awesome, and you were really excited for the issue brief to come out. So I do hope people will sign up to get that, as well as for the next webinar. But for now, we have the opportunity to speak with Hugh O'Hara. And Hugh, to kind of kick things off, I was just hoping you could tell us a little bit more about yourself, your daughter Rory, and your experiences navigating the private health insurance system following her type 1 diabetes diagnosis.
Sure. As Christine said, my name's Hugh O'Hara. I have an 8-year-old, or a 16-year-old daughter who was diagnosed when she was 8 years old with type 1 diabetes. And anyone who's gone through that knows that that's a life-changing day when you find out that a child has that, or you yourself have it. And from the very first moment I heard that she had diabetes, you start in your head doing that mental math of what does this look like? What does our insurance cover? What is going to be the long-term outcomes here? So one of the things we did is I think many parents do in that situation, many individuals, you quickly go online and start looking for resources and tools to help you navigate this new challenges in life. So we ended up getting connected with JDRF, which has since rebranded to Breakthrough T1D. Went to a walk. That was sort of the first event that we got involved in, a fundraiser. And then Rory had the opportunity to apply to be a youth ambassador. And one of those roles, and one of the really great things that they do, is they use a lot of the kids who are engaged, who want to be engaged and advocate for themselves. They give them opportunities to do that through their youth ambassador program. So we did a couple meetings with our local congressional rep. Went really well. They realized that I knew some people in state and local government and got roped into a larger advocacy role, and have since gone on to become the chair of, or co-chair of advocacy for Breakthrough T1D in Illinois. So do a lot of volunteering in that space, and we do outreach all year long but centered on annual trip to DC. And then every 2 years, we do what's called a Children's Congress, where we bring kids from across the country to DC in the summer, and they get to lobby their reps and senators and talk all about type 1 diabetes and the challenges that they have. And let me tell you, it is very hard for elected officials to say no to small children in matching T-shirts when they come in and ask for things. So it's a great opportunity.
That's amazing. I'm very glad we have you and your daughter and the other kids out there advocating for this. Now, so as Amy alluded to, we know that insurers and insurance plans can vary quite a bit in terms of the types of insulin and CGMs and pumps that they'll cover. How important has it been in your experience for an insurer to cover different brands and types of insulin pumps and CGMs all within one plan?
It's hugely important to cover all the sort of available options. Insurance companies, in our experience, and what I've heard from other, whether it's family members, team members, etc., the device that you use and the way that you manage your insulin is definitely a personal choice, and it's not a one size fits all option. Just as a couple of examples, several years back, one of the large insurers was not willing to cover the tubeless pumps, that a lot of people like to have, whether that's for they work out a lot, they don't want the tubes, they just don't like the feel of a tube on them. We noticed that a lot of individuals that may have other conditions where they have sensory issues, definitely having that extra tubing around doesn't really work. Small kids, if you can imagine, a toddler, oftentimes will rip out the tubing, not on purpose, just doing things toddlers do. So making sure that people had that choice was a big deal. And through the work of advocates, not only with JDRF at the time, but American Diabetes and others, we're able to get the insurance company to change their stance on that. That sort of has continued a little bit into the types of closed loop systems that different insurers will cover. Some will only cover one or two of the closed loop systems. Some will only cover one specific brand. And those brands don't always work the same for every individual. I know Rory was on one particular brand. It had its own CGM, and that CGM for her, for whatever reason, just did not work. It was often off by 30–40% on what her actual blood glucose levels were. So when you're dealing with challenges like that, and you have those different things happening, the access to a variety of pumps, CGMs, all of that matters a lot. I like to equate it to, if you had some private group telling you what kind of cell phone you could have, people would lose their minds. Now try to have private insurance telling you what type of device you can connect to your body all day, every day for the foreseeable future.
That's very powerful. And as soon as you said the tubeless option versus tubes, all I could think about was my toddler and baby pulling those out, right? It just would not work for me in that situation.
And there's
And
all kinds of things that take them out: dogs, cats, other kids, doorknobs.
yep. Now, can you walk us through from that patient perspective, what happens and what does it look like when an insurer makes a change in the types of insulin or supplies that they cover mid-year? What does the patient do in that situation?
First, you have a little bit of shock and panic when you're standing at the pharmacy counter and you go to pick up. A lot of times this happens with insulin, and you may be on, say, just for an example, you're on Humalog, you go up to the insurance or to the pharmacy counter, you go to pick it up, it's going to be X amount for your 90-day supply, and you find out that it's 5 times, 6 times, 7 times what you thought it was going to be, because that's no longer the preferred brand of your insurance company, and they have switched you from Humalog to Novolog. That's their preferred brand, and now you've got to either pay right then and there for the insulin at full cost, or B, go back and try and re-navigate the insurance system. So generally in those cases, assuming you don't need a vial immediately and you're not in that position of you have to make a decision right then and there at the counter, which does happen sometimes, you have to go back to your doctor, get them to switch you to the now preferred brand of insulin. And more or less, we find that they're interchangeable, but that's not always 100% the case. There's always special cases out there. But then you just have to go back and re-navigate that whole system and spend, part of your afternoon on the phone with your pediatrician or your doctor, your insurance company, make sure that they've got the new order, that they're not going to double it up on you and say that, well, we had this original order and you can't reorder for 90 more days. So all those things just add other stressors, other decision points onto not only the patients, but their families as well as they try to navigate all this. And if you're lucky enough to have a doctor that is very responsive, that has a great nursing team, that has a great team behind them, that, you can make that phone call and get that change made that day, that's amazing. And it's hugely helpful. But if your doctor's a little harder to get a hold of, if you're in, particularly in a rural area where you may have to, go great distances, they have a ton of patients, you don't have quite as much, the response time might be a little bit longer. That can really be a challenge for anyone trying to navigate that system. And that can happen. Insulin is the most common thing that would happen with, but it can happen across all the things that you need to live with type 1 diabetes.
That's a huge burden that you're dealing with on top of working or going to school, taking care of your family. Those hours add up very quickly.
It's hundreds and even it's hundreds of decisions a day that people living with type 1 diabetes have to make that the rest of us just don't have to worry about.
Mm-hmm.
And that adds up.
Yeah. And you mentioned kind of the CGMs, pumps, other supplies. We hear a lot about insulin copay caps, but what does cost sharing look like to you for these other diabetes services and supplies? And can patients afford that?
It really comes down to coverage. I did just before we came on today, I went and pulled our insurance claims for the last month just to see sort of where we're at. And I want to say it's somewhere around 12 to 1500 for Rory last month. I didn't have enough time to go back and look to see if that's completely average, but that's just all the supplies, whether that's your sensors for your Dexcom when you need not just the sensors, but then there's the transmitter that goes with it. There's your pump supplies. There's making sure you have glucagon. And if you're a student, you want to have one at home and one at school so that you're ready in case there's an emergency at school. All those costs add up. Lancets, the alcohol wipes. It's like one thing on top of another. That you have to get into. And in a lot of cases, that's covered. In some cases, it's not. And so, what we're seeing though is that by covering things like CGMs, like the artificial pancreas systems and the pumps, is that the results are better for individuals. As was sort of mentioned at the top, a lot has changed since a lot of these rules were written in the 90s. Back then, a big thing was looking at what your A1C is. That's still an important indicator today. But now, because of technology, we're really focusing on time in range. How often are you within that healthy range of your blood sugar? And you can't tell that unless you have these devices. So it's really important for coverage for all of those devices because insulin is obviously the most important thing. If you don't have that, the outcomes are tragic. But all of these things are going to stop those long-term problems and those big cost drivers later in life for these individuals.
That's a really good point, right? This is taking good care of yourself now. It's a huge savings longer term, but it's costly for the patient regardless. And
Absolutely.
pivoting a little bit, as the parent of a teenager with type 1 diabetes, are there insurance coverage and affordability considerations that are really top of mind when you're thinking about adolescents and young adults with diabetes rather than adults?
Yeah, I think that there's sort of two big changes that you go through in that span. One is if you go off to college or you move out for the first time, you're probably still on mom and dad's healthcare coverage, but you're going to be further away. You may be out of state, you may be across the country, et cetera. And navigating that, just how do you get just the logistics of it? How do you get those supplies to your student? Do you have to make sure your student in college has maybe a little extra room to store all of this stuff? Because if they're only coming home every once in a while, it is, a massive amount of extra just material that you're taking with you to school. making sure that you've got a refrigerator so that your insulin stays cold. You just got to make sure that all these extra things happen, and that is certainly a challenge. And I know a lot of parents who use that as sort of the training ground for that's when their child will start being the one who they have to make those phone calls to the insurance company. They have to make sure to reorder supplies from their doctor, usually with mom and dad's help and keeping an eye on them to make sure that they're doing it, but sort of putting those training wheels on and letting them go a little bit. And then when they move into adulthood, as far as the insurance carriers are concerned, at 26, that's a huge issue. And it's something my daughter really wants to go into the arts. The arts famously don't have the most stable career path. Insurance is up and down. It could be all over. And that's decisions that we talk about a lot, is how are you going to manage your diabetes if you go down certain career paths? And I know that that's a big issue for a lot of individuals, whether it's folks in the creative space or individuals who want to go into the entrepreneurship space, start businesses, et cetera. The first thing they have to think about is how are they going to have coverage? How are they going to pay for these things going forward? And that's tough. Even where you live, as was alluded to earlier, if you live in a more conservative state that maybe doesn't have as much coverage on these things and mandates on coverage, that's something that you have to think about. And it's unfortunate that that's the case, but it's where we're at. And you do have to have sort of very tough conversations that you shouldn't have to be having at that point in your life about where do you live and what career decisions do you make based on health insurance coverage.
Absolutely. That is a lot to navigate. And Hugh, thank you so much for providing this information to us. We're really looking forward to hearing more from you when we turn to the audience Q&A. But now I do need to move on to our next speaker, Kyla. Kyla, thank you for joining us. We're really excited to hear from you as well. And to start things off, could you tell us at a high level about the Colorado option, your goals for the program, and what's special about what the Colorado option plans are doing and how they're approaching diabetes coverage?
Sure, and thanks, Christine and Georgetown and Hemsley for having me. So the Colorado option is one of our state's key initiatives to save Coloradans money on their healthcare. Governor Jared Polis signed the Colorado options implementing legislation into law in June of 2021. And our legislation is pretty clear on our goals for the program. Two of those main goals are really to control healthcare costs by lowering monthly health insurance premiums and to improve racial health equity and reduce racial health disparities. In support of those two goals, the Colorado Option Program creates a standardized health benefit plan. These Colorado Option standardized plans, or Colorado Option plans, as we call them, are stakeholder-informed health plans with the same cost sharing for the most common services. Companies must reduce the price of these plans, and they must include a provider network that is culturally responsive and representative of the community. Companies are required to offer Colorado option plans in counties where they offer other plans. And these plans are available to both individuals and families who are purchasing their health insurance coverage in our individual market. So that's through our state marketplace, Connect Health Colorado, or off the marketplace. And these plans are also available to small employers who are purchasing coverage for their employees in the small group market. Colorado option plans, they first became available to those two places, right, in the individual family market and the small group market in 2023. And by the end of the 2024 open enrollment period, a record of 80,655 people had enrolled in Colorado option plans through our state marketplace, Connect Health Colorado. And that was an increase of 188% over our 2023 open enrollment period. So we're really excited with those numbers. And I think a key reason that these Colorado option plans have been so popular is because they have predictable and transparent costs, right? So as I think Amy gave a great overview of, right, that means that deductibles, co-payments, co-insurance are the same across all plans, regardless of which health insurance company is offering them. So the plans they also use co-payments, so that's that dollar amount, more than co-insurance, that percentage amount. And by applying more co-payments to the most common set of services, this really makes it easier for a consumer to know their out-of-pocket costs when they're going to their doctor or prior to filling a prescription. And then lastly, I'll just add that these plans also provide many first dollar or pre-deductible coverage that is free for high value services. So that's $0 copays for primary care non-preventative office visits. That's $0 copay on a mental health office visit. That's $0 copay on maternity care visits. And it's $0 copay on diabetic supplies, which includes CGMs. And then we also apply a very low first dollar kind of pre-deductible copay on diabetes self-management education. So we apply a $5 copay there as well.
That's great. And can you tell us a little bit more about why and how Colorado included diabetes services kind of in those, bucket of coverage that like have the $0 or really low dollar copays in your standardized plans? And what data did you look at to drive that decision?
Sure. So the Colorado option standardized plans, they were informed, as I mentioned, I said they were stakeholder informed plans. What that means is we had intensive stakeholder processes that brought in health insurance companies, consumer advocates, providers, brokers, and the business community. And we started those right after the Colorado option was signed into law. So we started those in the summer of 2021. We hosted 15 public meetings on the Colorado option plan design. We outreach to 96 organizations across the state to hold one-on-one meetings, small group meetings. And probably no surprise to folks, right? As part of these discussions, we heard a lot of things, but one relevant to this conversation is there really was a need to lower the cost for chronic disease prevention and management. So we heard those from those conversations. And then in addition, we brought in our partners from our public health department, CDPHE, to share data on the key health disparities across our state. And this data from our partners at public health really helped the division prioritize how it could best use our standardized plan design to advance health equity. And as part of that process and in discussion with stakeholders, we chose diabetes and prediabetes as one of our areas of focus. And really, when we're talking about diabetes, we don't kind of stratify between type 1 and type 2. We're kind of agnostic to that as right diabetes in general. And really that focus of saying, okay, one of the areas that we're going to focus on is going to be the pre-diabetes and diabetes prevention and management. We then said, how can we address that with the plan design? Well, that's where we put in the requirements around the diabetic supplies, including continuous glucose monitors being at no cost to the consumer. That's where the requirement came in, where we said when there's outpatient education for pre-diabetes, when it is recommended by a provider, it must include a program recognized by the National CDC Diabetes Prevention Program. That needs to be part of the diabetes prevention coverage through this plan. And then again, the diabetes self-management education with that low copay of $5.
That's great. And when recognizing some of these items and services are expensive. And so when you were deciding what to include in the Colorado option plans without cost sharing, were there any services that were, tough calls or required more conversation than others did?
Yeah, so developing a standardized plan or really doing a health benefit plan design within the ACA markets, so the individual and small group markets, that can be a challenge in itself because federal requirements in the ACA markets require the plans to fit within metal tiers, right? The bronze, the silver, and the gold. Each of those metal tiers has an associated actuarial value range where the plan must fit within in order to be compliant. And that actuarial value is really kind of telling the generosity of the plan. Like on average, how much is the plan paying for the consumer services. Bronze, the consumer pays more out of pocket but has a lower premium. Silver, the plan pays a little bit more out of pocket, it has a little bit higher premium than bronze, right? And then goes up to gold, right? Where that's going to be the consumer's paying the least amount, right? There's a lower out-of-pocket cost, but a higher premium, right? So we have that constraint in itself where, every kind of tweak that we make, we have to make sure that we still are fitting our plans within that. And I know that's like a little wonky, but it is something, a reality that makes really the trade-offs somewhat difficult when we are wanting to ensure that we are having low out-of-pocket costs and low premiums, right? You heard that the gold plan has the low out-of-pocket cost, but it has the higher premium. So there are the trade-offs that we have to continuously make. And then in addition to that, right, our administration is very focused on saving people money on healthcare. And one of the, the key pillars of the Colorado option is reducing premiums, right? So we have to balance all of that when kind of tweaking the plan designs, but we do have North Stars as part of the process, right? So I'm trying to make sure that we are being cognizant of any impact to premium as we lower cost sharing for certain services. But also, our North Stars, we're really applying first dollar pre-deductible coverage to high value services such as primary care. And then prioritizing co-pays on certain services over co-insurance, hoping to make that more predictable and more transparent as far as costs for folks. And those things actually do impact people living with diabetes, right? If we are allowing $0 copay on primary care, a copay on specialty, having them understand every time they go to their specialist for their diabetes care, they know what's happening, right? As well as applying copays to prescription drug tiers. Like we think that is still kind of helping that community. I will note though, the place that we didn't get across the finish line was really around lab services. So that was something that we heard a lot about in our stakeholder meetings is, and that affects so many enrollees, right? Laboratory tests. If we could apply a copay there, have it be low cost, and just given the considerations of, trying to stay within these metal levels, trying to be cognizant of premium, we just were not able to apply a copay and a low copay to lab costs. So those do have a coinsurance, that percentage amount for enrollees in option plans.
Got it. And that's an interesting kind of trade-off between a standardized plan approach where you have the state coming in and kind of making these trade-offs and trying to figure out, what's the best plan design overall for potential plan members versus, a statewide insulin or CGM copay cap that just is kind of like, this is what, all plans need to have it set at, and basically leaves it to the insurers to figure out like, okay, how are we going to make that work with our premiums and actuarial value requirements that might apply? Now, so then thinking about, going forward, how do you monitor whether the plan design is working to increase access and affordability for diabetes? Are there data sources you're looking at? And, how could this inform, what you do in the future?
Yeah, so currently our best way to understand how things are working for consumers is through our consumer services team and direct connections with stakeholders, such as those consumer advocates and brokers. Brokers have been actually really essential in lifting up consumer concerns and things that haven't been clear as far as the specific diabetes coverage requirements we have in Colorado option plans. So the division's consumer services teams, they work directly with consumers and the health insurance company to address one-on-one kind of individual complaints regarding coverage of diabetic supplies. And since January 2023, when the Colorado option was first available to purchase, right, the division has received several complaints that health insurance companies were not properly covering CGMs at no cost sharing, or that third-party administrators were unfamiliar with the Colorado option coverage requirements. And, as a result of the complaints that we were getting, right, the division issued guidance to carriers, our health insurance companies, to address these kind of unclear coverage requirements in the hopes that, our guidance would make things more clear. And that came out after the start of plan year 2023. Additionally, we also utilize our annual ACA plan filing process to ensure compliance upfront with our regulations, right? We're able to review health insurance company forms and policies that go in front of consumers to make sure diabetic supplies that are covered at $0 are listed there, right? So hopefully consumers and brokers have that information at plan shopping. And then we are required to continuously hold stakeholder meetings if we are going to make any changes to the standardized plan designs. As of last month, we held a stakeholder meeting to continue to get feedback on how the implementation of our coverage of diabetic supplies is going with the Colorado option. And, that was at the end of September. It's now the end of October. Like within that kind of 30-day time period from having that stakeholder meeting, we reissued guidance to try to make these requirements even more clear based on the feedback that we primarily heard in those meetings from brokers who were still helping their consumers, and things weren't as clear. So we're continuously trying to improve and make edits to our requirements and our instructions as we go. And lastly, I'll just note that there is a evaluation of the Colorado option program kind of writ large that is due to our legislature January 1 of 2026. We just brought on our evaluator for that. And so, that's a little bit broader scope of how the Colorado option is going, but we would expect how is the standardized plan design, right, to have impacts there in the evaluation. So that's something to look out for. And I'll just, if this is the time, I think I'll just give a good kudos to our Colorado option team. They're small but mighty, but we have a director, Sarah Bensick, and a program assistant, Maddie Davis, who, do all of this work with our consumer services, our stakeholders, our brokers, right? They're updating the guidance. They're working with our rates and forms team through the plan filing process and really doing a great job trying to keep a pulse of how these coverage requirements are going for consumers in reality.
That's great. And I will say, just from, following what the Colorado option has been doing for years, I think your transparency around your processes and your engagement with stakeholders, it has been very tremendous. So thank you for all of that work that you and your team have been doing. And maybe just to end by stepping back from the Colorado option briefly to look at, statewide, Colorado also has implemented caps on the cost of insulin. And I just wanted to ask, your opinion on how important is that insulin cap to improving affordability, and kind of are there other approaches outside of the standardized plans that you see as helpful here?
Yeah, I think when I think of how an insulin cap impacts the consumer, I think about that predictability and the transparency of what it's going to cost me, right, to have a life-saving drug to manage my diabetes. And right, so, I think it's extremely important to have predictable and transparent costs and to make it as affordable as possible. So our Colorado's insulin cap actually was passed at state legislature at the same time as that option. And so, that is one of the reasons we didn't touch kind of the cost sharing on insulin specifically within the standardized plan, is because, what that legislation was like specifically passed. We had it on the books. We wanted to see how things were going. And so that's something that we haven't specifically touched with Colorado option plans. But I would say, we continue to have the limitations in creating a benefit design that is both affordable from an out-of-pocket cost standpoint and a premium standpoint as well. So that's something that we always have to consider.
Got it. Thank you. And I'm gonna direct questions to the Q&A button, but there is one just in the chat that I'm gonna just ask you, Kyla, real quick right now while we have you still. And it's just, do the bronze plans have the $0 copays you described, or is that only silver and gold?
So for our bronze plans, I'm pulling it up to make sure I don't misspeak on anything. So for our primary care for bronze, we have the first 3 visits are $0 pre-deductible, and then it's the co-insurance kicks in. Mental health, it is $0 unlimited. So there's not an office visit or like a visit restriction there. And then for the maternity care, it is similar to the primary care where it's the first 3 visits are $0 pre-deductible.
Got it. Thank you. And so, Kyla, thank you so much for sharing all of your expertise with us. And I really can't wait to see what Colorado does next under your leadership. And with thanks again to Amy and Hugh as well, I'd like to now open up the floor for audience questions. Again, submit your questions through the Q&A button if you haven't already. That's in the Q&A box at the bottom of your screen. And I think I'm going to kick things off. We have a question about EHB benchmark processes. And so, Amy, I might give this one to you of just whether, are you aware of any states that have updated or are considering updating their EHB benchmarks to improve coverage for patients with diabetes care?
Yeah, it's a great question, and I would say the answer is yes, but we're sort of monitoring this. It's a bit of a moving target right now because the federal government has just made it a little bit easier for states to update their EHB benchmark plans. And so with that change, we're sort of seeing now states figuring out if they're going to go and do the process to update their EHB benchmark, which makes good sense in a lot of states, given that a lot can change year to year, and particularly since when some of the first benchmarks were chosen. To the question about diabetes specific, there's 2 answers to that. One, right now in the benchmarks, there are diabetes standards in there because the benchmark plans are based on an existing private insurance plan out there. And so if you go to the benchmark that was chosen in every state, there are diabetes services in there that are providing a standard for the plan subject to essential health benefits in the state. So that's already out there. Even without any changes, you have diabetes standards within the EHB benchmark. I think in terms of the opportunity to plus up those standards, we're waiting to see what happens. We have seen one state, North Dakota, so that was not one of our study states, but we did look at that EHB benchmark. They did something kind of interesting that I'm not sure we'll see in other states. They used the benchmark to get at cost sharing for diabetes services. That is a bit innovative. Cost sharing was not originally included in EHB benchmark. It's really just benefits, but states, particularly in states where the legislative routes are narrow or non-existent, looking at what is the full universe of what we can try to include in the EHB benchmark, we'll start to see that happen. So that's something we're watching very, very closely.
Great, thank you. Another question, and I'm going to generalize this a little bit from the question that came in the Q&A, but it's asking about kind of the distinction between covering diabetes supplies and equipment under a prescription formulary or as DME. The question in the comments is about Medicare. You know, we're focused on the commercial market here. Hugh, I might kind of first just ask about kind of your experience with this, and then turn it to Kyla to see kind of whether how Colorado Option plans if you distinguish between DME versus formulary benefits for these sorts of supplies.
In our experience, we've actually personally dealt with that where it was easier to switch Rory's Dexcom to being a prescription as opposed to a medical device. For our insurance, it was able to make things just a whole lot easier in the process. It does cost, in our case, a little bit more out of pocket because we have a copay on prescriptions and not on durable medical devices. So, you know, for us, the choice was somewhat easy. It was just worth the small copay to make it worthwhile. But that change, you know, it really depends on your individual coverage and what your, you know, priority is. Is it ease of getting supplies or is it all about cost? And you've got to weigh those 2 things out. So it really comes down to what the individual wants to do in that case and what part of it's what their provider is aware of and what options are out there for them.
Thanks, Christine. So I will say from the Colorado Option perspective, this is something that has been brought up as a point of confusion for consumers and brokers on behalf of consumers, which is not understanding, you know, whether or not these diabetic supplies are considered a pharmacy benefit or a DME. If they're DME, like how do they access information from the supplier, right? Like where do they go to get this information? And so because of that feedback that we did provide that guidance shortly after, plan year 2023, and then recently, as of this week, we adopted changes to the guidance to ask carriers, health insurance companies, to make this information a little bit more clear to the consumer by posting on a website whether or not these supplies are covered under pharmacy or DME and how to access them, right? I think we did hear some feedback from health insurance companies that suppliers can change and all of that, and really our guidance is around, what now, the information that you have now, like, please make that available to consumers in an easily accessible and understandable way.
Very helpful. Thank you. Amy, do you have anything to add on this point?
No, I think you and Kyla have covered it.
Okay. Didn't want to leave you out. Then, I think, I realize we're getting near the end, but first I want to see, we've talked a lot about insulin and diabetic supplies. And so I've gotten a question about, are there other services that are really important for a patient with diabetes to, make sure that they have access to and that it be affordable? Kyla, you briefly mentioned the labs, and also the primary care. Are there other things that's on the table as important services? And maybe Hugh, I'll start with you as giving that patient perspective.
The access to mental health care is hugely important. Like I said earlier, you're having to make hundreds of extra decisions a day, and you're trying to do that as a 10-year-old, and that puts strains on anyone, but imagine that particularly children, even adults. Obviously, it is for any chronic condition, I think having that access to mental health care is hugely important. And we're seeing more and more people in that space that are specializing on working with individuals who do have chronic conditions, and the stresses and strains that go with that, and having to handle that throughout your whole life.
Wow,
I'd say that's definitely the number one, sort of outside of what's there to keep you alive. The mental health care and having access to that is massively important.
that's a hugely important point. And I think, right, just thinking about all of us holistically, right, it's a bigger picture than just our lab work and all. So thank you for that point, Hugh. I think that's really valuable. We're now coming up on the hour, so we'll need to stop there. My thanks to all of our speakers, as well as to everyone listening in today, and to our funders at the Helmsley Charitable Trust for making all of this possible. I hope you enjoyed today's webinar as much as I did. We'll be hosting a second webinar in the series on prior authorization on December 6th. We know this is a hot topic and hope you all be able to join us. In the meantime, keep your eyes peeled for more information on that. We'll also have an issue brief coming out in December too. So thank you, and have a really happy Halloween tomorrow.